So good morning everyone. I hope you all are doing well. So these are difficult times. We cannot meet in real life, and this concept of virtual teaching is really great. So we all should understand that no matter what, learning should never stop. Okay, so we are here from the Department of Neurosurgery today, and today we will be discussing about the functional and surgical anatomy of pituitary gland. We will be discussing more from the neurosurgical point of view. We will be discussing about the neurosurgical microanatomy, but we will not be going into that much of depth. We will only touch to the extent that is required at your level. So let us start. But before starting, I would like to make concepts clear about what are the sagittal plane, transverse plane and frontal plane or coronal plane. Because we get our observers, interns and house officers in our department, they really don't have a clear-cut idea when they see a picture or a scan, CT scan or MRI films, and they cannot really tell what cut it is taken in. So usually you will see sagittal cuts, transverse cuts or axial cuts, or also known as, and the third one is coronal cuts. The easier way to remember is this: you just look at the sutures. Okay. So if you see here, this is the coronal suture. So anything that is along this axis, these are coronal cuts. Also, if you see the sagittal suture here, so any cuts along this plane will be the sagittal cuts, and axial cuts, they will be along the cross-sectional cuts or axial cuts. Okay, so the first one over here, it's axial cuts. This is the cross-sectional. This is the view in this plane is coronal cuts, because remember they are again aligning with the coronal suture. And finally the third one here is in sagittal cuts. You are seeing it from the side, and this runs along the sagittal suture. So this is taken in a sagittal cut. It is the mid sagittal cut of a human brain. You can see over here that the gland pointed out in this region, this small ovate gland, is the pituitary gland. This one. Okay, so this is resting in the base of the skull. All right. Posteriorly, there is brainstem. This is the midbrain. This is the pons, and this is the medulla. Anteriorly, this is base of the frontal lobe. You can see over here, this thing over here is the mammillary body. The one in front is optic chiasm. So this is the skull base, and this space you can see over here, it is sphenoid sinus. This is very important in pituitary gland surgery. Pituitary gland, or also known as hypophysis cerebri, it's a reddish gray ovoid body. It measures around 12 millimeters in transverse diameter and only 8 millimeters in AP diameter. So it is only around 500 milligrams, not even a gram in its weight. So it's half of a gram, and like I told you, it rests on the base of the skull. Okay, this is called as sella turcica. This space, a dip in the middle cranial fossa. At the center of middle cranial fossa, this is the area where the pituitary gland it sits. So let me tell you a bit in about the anatomy of the floor of any skull. So I'm drawing a line over here. You see that anything ahead of this line, in front of this line, like this area, it's anterior cranial fossa. Okay, posteriorly, from the petrous part of the bone to the dorsum celli, this area. Posteriorly, there is occipital bone, clivus. All these parts are posterior cranial fossa, and the one in the middle, behind the wing of sphenoid bone, these are all middle cranial fossa, and this is a part of sphenoid bone as well. So pituitary gland sits in the sella turcica, which is a part of this sphenoid bone. So the sella turcica is composed of hypophyseal fossa, this fossa in the middle. This is also known as pituitary fossa. Anterior to it is tuberculum sellae. This is a bony protuberance anterior to it. So posterior to hypophyseal fossa there is another bony protuberance which is dorsum sellae. So we will be seeing it in this picture. So this is the pituitary fossa. Anterior to it, this ridge, this one over here, it's tuberculum sellae. The one posterior to it is dorsum sellae. Okay, so all this consists of sella turcica. So do you see this groove over here? This is the area where optic chiasm rests. So optic nerve from the right side comes from here. It's over here. The superior orbital fissure is over here. This is round in structure, if you see it clearly. So this is, since it's round, this is also not known as foramen rotundum, and this is oval in shape. This is foramen ovale, and this is foramen spinosum. From here, V2 branch of fifth cranial nerve passes. From here, V3. So since this is just extra information for you, this is foramen spinosum. So from this you can see the groove coming outside and it is dividing. So this marks as the area where middle meningeal artery comes out, divides into anterior branch and posterior branch. And you know, middle meningeal artery is one of the most common artery that is ruptured and that gives rise to extradural hematoma. So this is the most common area of extradural hematoma formation, and this is the foramen spinosum from where the middle meningeal artery comes out. This is the carotid canal from which the carotid artery comes out. This is the foramen lacerium. It doesn't come out from here. Carotid artery enters the skull from here, goes here. So this is a carotid groove. Okay. So on either side there are two carotid grooves. It goes this way, comes in front, makes a loop in the cavernous sinus and goes up, divides itself laterally into middle cerebral artery, and medially and anteriorly into anterior cerebellar artery, which we will see in a while. So let's proceed towards the pituitary gland. So you all know it is composed of two lobes, the anterior lobe and posterior lobe. This picture and this picture, it shows superior view from superior end, and this is the view from the inferior end. So this shows surfaces of glands in which the anterior and posterior lobes form a relative ovoid structure. So the pars tuberalis, the one you can see over here, wraps partially around the pituitary stalk, this one. In this picture, the anterior and posterior lobes have been separated, and what you can see here is the stalk joins the anterior superior surface of the posterior lobe and is partially surrounded by pars tuberalis, this one. So so this is the hypothalamus, okay, and this is the medial eminence. This is optic chiasm. Anteriorly, posteriorly there is a mammillary body. So the medial eminence, it comes down, joins the part of posterior lobe of the pituitary gland. So we call it as neurohypophysis. It consists of infundibular stem in the middle, median eminence of tuberous cinereum superiorly, and inferiorly posterior part, that is infundibular process. The anterior lobe of pituitary gland is called as adenohypophysis. So it consists of three parts: pars tuberalis, pars intermedia, and pars distalis. So pars tuberalis, we saw it in the pictures a while ago that it wraps around the stalk, pituitary stalk. Pars intermedia is actually rudimentary in adult pituitary gland. So moving on to the next slide. So pituitary gland is continuous with the infundibulum, which is a hollow conical inferior process from the tuberous cinereum of the hypothalamus. It lies within the pituitary fossa of the sphenoid bone, where it is covered superiorly by circular diaphragma sellae of dura matter. We will see it in a while. The latter is pierced centrally by an aperture for the infundibulum and separates the anterior superior aspect of the pituitary from the optic chiasm. So this slide in a easier way is demonstrated here. So remember, we are looking at this portion, okay? We are only looking at this portion. So here, as you know, the meninges of brain, they are divided into 3 subgroups, or there are 3 types of meninges. First one is dura mater, second one is arachnoid mater, and third one is pia mater. So dura mater is not just a single layer of tissue, okay? The sheet of dura mater is actually composed of 2 different layers. The inner one is meningeal layer, which is close to the arachnoid part, and the outer one is endosteal layer, which is actually running together with the bony surface. So this is the meningeal layer, and the one below is the endosteal layer, and this is the pituitary gland, this is the infundibulum and stalk. So you see the inner part meningeal layer, it is forming an extra round like structure over here, okay? So it is compressing around the infundibulum and forming a tight vest like structure for this whole thing, okay? So this is separating pituitary gland from all the rest of the intracranial structures lying above it. This is one of the reasons why we can avoid CSF leakage after transsphenoidal surgery, because of this extra layer of meningeal layer, and this one is called diaphragma sella. Now whenever you see an X-ray of the skull in lateral view, can you see where the pituitary fossa here is, or sella turcica? Can you see where the sphenoid sinus is? All right, so we will show you again. This pit or dip, this is the sella turcica or pituitary fossa. This one is tuberculum sellae. The one at the back, this one is dorsum sellae, and this pneumatized structure, this radiolucent structure is sphenoid sinus, okay? So this is why we use transsphenoidal approach to reach to the pituitary gland. This is one of the newest form of surgeries. Before, they used to go through the cranium to operate on the pituitary gland, but now we go through the nose, transnasal, transsphenoidal. We go towards the sphenoid, we break all these structures, break the base of the skull, and then we operate on this one. We will be discussing it in next coming chapters. This is again another view this is a superior view. You can see over here that this is the pituitary gland with pituitary stalk in the middle. So it is covered by intercavernous sinuses, this one all over. This one is cavernous sinus, there are one on either side, okay. These red structures are ICAs, internal carotid arteries, on either side. So you see how important it is during operation of pituitary gland to avoid any injury to the ICA, because the patient can bleed to death on the table within minutes. And the one in front, this one and this one, the whitest structure that is coming from this foramen, optic foramen, this one is optic nerve, okay. So they two come behind and then they meet here in the middle transversely as optic chiasm, yes, and the optic tract, it will follow this way. So again we will go into a magnified view of the same thing. So this is the optic nerve, this is the cavernous segment of the ICA on either side, this is the anterior lobe. The bone on the right hand side has been removed just to expose the posterior lobe. This is the pituitary stalk again. The third nerve, you can see it's running on the either side, but it's too far lateral. There are two main blood vessels that supply the pituitary gland. The inferior one is called inferior hypophyseal artery. This travels medially from the intracavernous carotid to the posterior lobe. Okay. So next we are seeing in a coronal plane now how it looks like. This is the pituitary stalk, this is the pituitary gland, these are the optic nerves, this is the chiasm. Okay. So on either side there are cavernous sinuses. There are intercavernous sinuses that run in between these two sinuses, above which the pituitary gland rests. So below the pituitary gland there is a pair of sphenoidal sinus. Okay. So the contents of cavernous sinus, they are ICA, sixth cranial nerve, which runs very close to the ICA, the cavernous segment of ICA. So while doing any surgery of cavernous sinus, we have to save and protect sixth nerve, otherwise patient will develop extraocular muscles weakness and also diplopia because of it. So the first thing to save is sixth nerve. Identify and save the sixth nerve. The other structures that run in the cavernous sinuses are this one, oculomotor nerve, 3, trochlear nerve, 4, V1 and V2 branches of trigeminal nerve. V1 is ophthalmic, V2 is maxillary. So this is again mid-sagittal portion, mid-sagittal section of the sella. This is extending through the anterior and posterior lobe of the pituitary gland, and also the sphenoid sinus has been removed so that the structures can be seen properly. You can see the intracavernous sinus here that runs from one side of the pituitary gland to the other. You can also see this big red structure. This is the cavernous part of ICA, cavernous segment of ICA. These are the second cranial nerves, optic nerve. This is the pituitary stalk. This is the anterior pituitary lobe. This is the posterior pituitary lobe. Most of the adenomas of pituitary gland, they are usually in the anterior lobe, and carcinomas, they are in the posterior lobe, which are very, very low. So almost 90-95% of the cases of pituitary adenoma, whether it be microadenoma or macroadenoma, it is always in the anterior lobe. So moving on, this is now the coronal anterior view. The cavernous sinuses are located on the either side of the gland. Okay, so these are cavernous sinuses, and they separate the gland from the intercavernous carotids. Okay, this one and this one are separated. The superior hypophyseal arteries, this one on either side and one from this one, they arise from the middle side of the supraclinoid carotid. So this is the cavernous part of carotid, this is the supraclinoid part of the carotid, and this pass to the chiasm and the stalk here and here. So this is one of the major blood supply of the pituitary gland. The anterior intercavernous sinus crosses the anterior superior margin of the gland, this one, and the inferior cavernous sinus, it extends below the gland, interconnecting these two cavernous sinuses. So this is again the same view. You can see a very good depiction of superior hypophyseal artery. Okay, so this is the clinoidal part of carotid arteries. This is the stalk, this one is the optic chiasm, this one are the optic nerves in front. So what you have to take note from this slide is, whenever this pituitary gland tumor becomes big because of any edema or any necrosis, hemorrhage there, or by the enlarging size of pituitary microadenoma itself, it firstly and foremost it compresses this part of optic chiasm. Okay, so the very famous question, when the pituitary gland enlarges and it compresses the optic chiasm, it gives bitemporal hemianopsia kind of visual loss. So this is a very good thing to keep in mind. This will be asked for the rest of your life in your exams, major exams, USMLE or any other exams. So this is a superior view of the same structures: pituitary gland, the pituitary stalk, these are the superior hypophyseal artery, This is the infolding of dura that we saw a while ago, also known as diaphragma sellae. These two are the carotid arteries and these two are the optic nerves. So proceeding forward. So we have already discussed that it has two parts, neurohypophysis and adenohypophysis. Neurohypophysis, which is the posterior lobe of the pituitary gland. Its origin is from the diencephalic downgrowth, which is connected with the hypothalamus. And the one of adenohypophysis is ectodermal derivative of the stomatodeum, which is an invagination during embryological growth from which mouth and heart comes out, pericardium. So these two differ in their origin, structure and function, and both include parts of the infundibulum. Again, adenohypophysis is composed of pars tuberalis, pars intermedia, and pars distalis, or also known as pars anterior. The posterior part, neurohypophysis, is composed of pars posterior and infundibulum. The infundibulum, it has a central infundibular stem that contains neural hypophyseal connections and is continuous with the median eminence of the tuberous cinerarium. We will see this in the upcoming slides. So the neurohypophysis, it includes the median eminence, infundibular stem, and neural lobe, or also known as pars posterior. So you see the axons of the axons, they are running from the hypothalamus to the posterior lobe of the pituitary gland. The arterial supply, it's from the branches of ICA. I have already seen it in multiple pictures. So there are two superior hypophyseal artery and two inferior hypophyseal artery. These two both arise from the different segments of ICA on either sides. For the venous drainage, there are short veins from the pituitary gland that drain into the abutting dural venous sinuses. The hormones pass out of the gland via venous blood to the goal sites. So this is a portal system. So these are the superior hypophyseal arteries on either sides. These are the two inferior hypophyseal artery. So these arteries supply the median eminence, pituitary stalk, and the lower lobes. Again, this is another picture. You can also see the hypophyseal veins on either sides. Okay, and these are the superior hypophyseal artery, and these are the inferior hypophyseal arteries. Now, what is hypothalamo-hypophyseal tract? This is composed of nerve fibers that originate from the different nuclei of hypothalamus. They are mainly supraoptic and paraventricular nuclei, and they project downwards into the posterior lobe of the pituitary gland, the one we saw a while ago. So the vasopressin and ADH. The supraoptic nuclei, it secretes vasopressin, and paraventricular nuclei, it secretes ADH. Now, these two are secreted and then transported along the nerve fibers of the tract by the nerve fibers, and they reach the posterior neurohypophysis, and afterwards these hormones are released into the venous sinusoids. Remember that the posterior lobe does not secrete any hormone, it only stores that are already secreted by the hypothalamus. So these are the neurons in the so these are the different nuclei in the hypothalamus. They are supraoptic nuclei and paraventricular nuclei. They secrete the hormones, oxytocin and vasopressin, and they are stored in posterior pituitary, and they are released into the dural sinuses to the veins. So these are oxytocin and ACTH. Again, they are produced by the hypothalamus, transferred to posterior lobe through hypothalamo-hypophyseal tract. Now, in contrast, for the anterior lobe, there is something termed as hypothalamo-hypophyseal portal system. Remember, where else is portal system in your body? It's in the liver. Before the blood that goes into the heart from different GI viscera, it reaches the liver first. So there is another portal system in the liver, known as hepatic portal system. Similarly, we have hypothalamo-hypophyseal portal system here. So it includes two sets of capillaries, one in the hypothalamus, median eminence, and the other in the hypophysis cerebri, that is pituitary gland itself, in the sinusoids of pars anterior lobe of pituitary gland. The neurons of the hypothalamus, it creates the hormones. These hormones are releasing hormones like gonadotropin releasing hormone, corticotropin releasing hormone. Okay, so these are released in the capillaries of the median eminence and upper part of the infundibulum. These are then taken down by the portal system to the anterior part of the pituitary gland, where they excite the target cells. Those cells further release the stimulating hormones like thyroid stimulating hormone or ACTH. Okay, so this is the hypothalamic portal system or hypothalamo-hypophyseal portal system. So the hormones secreted by the anterior pituitary are growth hormone, thyroid stimulating hormone, adrenocorticotropic hormone, follicle stimulating hormone, luteinizing hormone, and prolactin. So this is a picture famously described in almost all the physiology books. So these are the hormones secreted by the anterior lobe of pituitary gland. They act on the target organs once they reach through the blood. So this is to show the same thing in detail, like what are the hormones produced by posterior and anterior. Sorry, this one by hypothalamus. They reach the anterior, and then they secrete the hormones. Now there is the target organs, and they have their effects. These are the references from which we took the contents and pictures from. If you are interested to know more about what we do in our department, you are invited to like our Facebook page. It's KEMU Neurosurgery. We also have the domain under kemu.edu.pk/neurosurgery. We usually get around a couple of interested candidates every year for observership even before they start their house up, and most of them are either our residents already, junior residents, or they are in the process. So if you are interested, feel free to join us, contact our registrar, see what we do in the department, observe our surgeries. I hope we will be able to influence you all to come into the field of neurosurgery. See you next time. Thank you so much.